I'm sure Mishra sir will be answering some of my doubts. So, firstly, this amazingly interesting. Cannot imagine. Firstly, we have been sent to Japan. Kikuchi-Fujimoto. Okay. So, could you tell, have you heard of Kikuchi classification? It's not your department, general surgery department. Can anybody from the department of surgery tell Kikuchi classification related to oncology? The classification of colorectal cancer is classified with various levels, various stages of colorectal cancer is Kikuchi classification. Well, this is the Japanese word. F-A-U-X-P-A-S. Have you heard this word, this phrase? F-A-U-X. P-A-S. Faux pas. Is it? Anyone? I'm sure. Those who are interested in French, it's like the mistake which I did. Kavya ma'am, I mistook her to be student. That's social embarrassment. That is known as faux pas in French. Social embarrassment in making a diagnosis is faux pas. Now let's come back to our topic, Kikuchi-Fujimoto. It's nothing but histiocytic necrotizing lymphadenitis. Well, the diagnosis absolutely went to autoimmune in Qatar. Here, the diagnosis was made, but after much late experimenting, suddenly lymphadenopathy was seen. Then it was sent for histopathic examination, and that clears the diagnosis. There is nothing but Kikuchi-Fujimoto disease. Earlier, C-reactive protein was very high. Could you show the slides? I think he has already removed everything. Have you removed? Could you show the slide? Where C-reactive protein is very high. They removed everything. Is that okay? Yeah, procalcitonin is also there. This says the infective element is definitely there. The infective markers are definitely there. So where things can go wrong? Where the diagnosis? Is it an autoimmune? ANA is positive? ANA is also positive. So ANA is positive, it directly goes toward something suspicion toward SLE. Well, and butterfly thing also?
Yes sir, that is also there.
That is also there. It's going towards. If it is the diagnosis Kikuchi-Fujimoto disease, as per my knowledge goes, it is absolutely self-limiting and innocuous thing which gets cured with or without treatment in a span of 1 to 4 months. Just what you have to give is just anesthetics. Like ibuprofen or painkillers, some symptomatic conservative treatment. Self-limiting. It has nothing to worry. You don't have to give treatment. That is the treatment. Conservative management. There is no role of steroid. There is no role of anything else. Going into this thing is no question. If the diagnosis Kikuchi-Fujimoto, what do you suggest? If the diagnosis Kikuchi-Fujimoto alone, without auto, MCTD also was diagnosed there. So how the diagnosis is? It can't be a mixture of Kikuchi also and SLE also. Either Kikuchi-Fujimoto is there or the mixture. Could you give the mic, please?
I think discussion is going far away from this topic. That's why
Sir.
actually, with the background of Kikuchi, first of all, congratulations to Ramnath.
Excellent.
He is a very hard-working guy. Coming to the topic, already the patient was having MCTD. So on the background of mixed connective tissue disorder, the patient developed a generalized lymphadenopathy in a setting of fever. So the today's discussion was generalized lymphadenopathy with the background of immunological disease like SLE and MCTD. So if you spare me 3-4 minutes, I will speak everything.
Please.
Okay. So coming to autoimmune disease, immunity, there are 4 types of hypersensitivity. Type 1, type 2, type 3, type 4. Type 1, allergy or immediate hypersensitivity. Type 2 is, this is I am speaking for the undergraduates. Type 2 is antibody mediated, that is also a kind of hypersensitivity, because all this hypersensitivity and autoimmunity means our body is reacting more towards the antigen, which should not be. Normally our body should not react to our own antigen. When body reacts to our own antigen, self antigen, it is called autoimmunity. And somewhere it starts with some infection or something. So you see most of the autoimmune diseases, they started with some infection. They were triggered with some infection. Infection produces some antibody and body reacts more to that infection. That is autoimmunity. So type 1 hypersensitivity, type 2 is antibody mediated. The typical example is hemolytic anemias. Type 3 is immune complex. So even type 2 also immune complex. But the difference is type 3, there is in vitro deposition of the immune complexes. So the immune complexes will be deposited in the renal tubules in the basement membrane, or it will be glomerulonephritis. Then it can be so different tissues we get the immune complex deposition. That is type 3. And type 4, all of you know, that is delayed hypersensitivity. The typical example is tuberculosis. And this case, already the patient was having, why is this type of things, why it happens in SLE or MCPD? I think clearly in the slides there was 30% of the cases there is coincidence, because SLE and the scleroderma, MCPD, they are hyper immunological states. So body reacts very fastly instead of very slowly to some antigens. So already body is in a hyperimmune or in a immunological state. And those kind of people, like say people of SLE and MCPD, if they develop some kind of infection, say viral infection like Epstein-Barr virus infection, or you can say CMV, or I will differ slightly with you, Ramnath, that those respiratory infections, respiratory virus infections, not common in Qatar. They are very common in India. Only thing, we don't do all these investigations. They have all the facilities, they did. In India also, in some of the Apex institutes, they do all these investigations. So, whenever the patient is exposed to any kind of infection, it will respond in a hyperactive way. That is lymphadenopathy. And the typical Kikuchi disease, the typical thing is, instead of responding only with lymphadenopathy, there is a necrosis. So that's called
Histiocytic
keratocytic necrosis. That is typical for Kikuchi's disease.
Typical,
Yeah, that is a typical.
Could you show that slide? A beautiful slide of the histopathology.
Yeah.
Karyolytic. That small breakage of histiocytes.
Yes.
Small portion. That's it. This is H is silent.
Yeah.
Karyolytic debris.
Yes.
That is karyolytic debris. Powder histiocytes. That is the typical of that.
Any lymph node biopsy, if there is histiocytic infiltration along with necrosis, then this is coming under Kikuchi-Fujimoto or anything. They name differently, but the manifestations are same. So in India also it is not rare. If we said for lymph node biopsy, most of these cases, we may get so many cases. And initially those two scientists, they discovered that the name is Kikuchi-Fujimoto disease. But it is a hyperactive lymphadenopathy with central necrosis, and only thing we differentiate it from tuberculosis by looking at the granuloma formation. Here there are no granulomas.
There is no diagnosis, it's 100% diagnosis correct.
Yeah.
When the diagnosis is correct, why are we giving steroids? It's a self-limiting benign condition.
No, it means it is not the treatment, but as you know, the patient was having also MCD, mixed cognitive disorder. That's why we started steroid. And the patient received NSAIDs and everything for almost 3 weeks. They are 2 weeks and here also 1 week. After starting steroid in the 5th day, patient started good recovery. Of course, steroid could have been postponed also.
But it can be avoided.
No, we could have been avoided. But we waited for 1 week, but the response was not there. Then we started steroid, and after that within 3 or 4 days, and it was a short course of steroid. Steroid is not like any atomic bomb or anything that it is there in the market, means it has to be used judiciously. And I will say, the role what steroid can do, no other immunological therapy, might be tocilizumab or kiflozimab or whatever, no other immunological therapy can do, because those immunological therapies, they target at very specific antigens, very specific sites. So there the thing is we are looking at the side effects. But steroid targets at multiple sites. So suppose imagine that say autoimmunity is a stage when all the panic buttons are on in the body. And if you want to check that panic buttons, you have to target as a whole. And steroid is the mainstay of treatment at that time. Then next thing will be how to reduce the side effects. So that's why steroid should be used judiciously. I was not involved in this case, only thing with the discussion, but there is definitely role of steroids, sir. And it is not that because why steroid means people they might take a wrong message. Because it is not that atomic bomb steroid. It is a very vital agent and the role what it can do, no other agent can do. Only thing we have to use it judiciously and for short course. Thank you.
Thank you so much, sir. Let's not invite our instructor and doctor. Excellent presentation. We move on to the next topic, Department of General Obstetric Gynecology, case of presentation of uterine torsion. Presenter is Dr. S.N. Shreya Bhuvanagiri, second year postgraduate student, and moderator is Dr. D. Murmu, Professor of Obstetric Gynecology. Please.
Good afternoon, respected dignitaries, faculty, and all my dear